Happy World Sight Day, everybody, and welcome to today's webinar, The Future in Focus, Eye Health in Canada and Beyond. Good morning, good afternoon, good evening. I know that we have people joining us from right across Canada, but also from as far afield as Europe and Africa. So thank you all for being part of this event on a day as important as World Sight Day. For those of you who don't know me, I am Drew Keys, the Director of Regional Engagement for the International Agency for the Prevention of Blindness. And it's my great pleasure to have been invited by three such significant Canadian organisations as Orbis, Seva Canada, and Operation Eyesight Universal to moderate today's webinar. Those organisations, and of course many others, are members of IAPB, which is the global peak body for eye health. And it was IAPB together with the World Health Organization that originally started World Sight Day. Today's World Sight Day of 2025 is the fourth or fifth year where we have been running the Love Your Eyes campaign. Love Your Eyes, of course, is designed to raise the profile of eye health amongst policymakers as well as the general public. And so it's really exciting today when we think about the topic and think about the work that's being done in Canada and see how far Canada has come over the last 12 months in terms of raising the profile of eye health in the Parliament and with policymakers by bringing together all of the various organisations. And we'll, of course, be hearing about some of that work today. It's also important to mention that in just over 12 months' time, the first global political summit for eye health will take place towards the end of 2026. And that's why it's really, really interesting to have people beyond Canada part of this webinar. But of course, coming back to Canada for a moment, it also helps to ground us in the fact that Canada is a leader when it comes to eye health, and we will be hearing about that as we move through today's agenda. Let me introduce some of our learned panelists who will be participating. We are going to be hearing from them in a few moments, and then we will have an opportunity for some questions. So please do feel free as we move through the agenda to pop your questions into the chat. We have some people working in the background who will be able to bring our questions through to me, and I can ask them when we get to the end of the panel presentations. But first of all, I would really like to welcome our participants. First of all, we will have Katie Judson. Katie has been Seva Canada's Program Director of Operations since 2022 and has many, many years of public health experience, management, healthcare policy, and global health program development. So welcome, Katie. We're really looking forward to hearing from you today. Secondly, all the way from Ghana, we have Dr. Boateng Wiafe. Bo is an ophthalmologist who works for Westburg Eye Services in Ghana, is a technical advisor for Operation Eyesight Universal. And if I can talk from an IAPB perspective for a moment, Dr. Bo is helping us very much with developing Ghana's agenda for the Global Summit in 2026. We then have Kris Kelm, and Kris, of course, is from Operation Eyesight Universal, is the International Programs Director, and is also the chair of the Canadian Eye Health Coalition. I was just mentioning some of the great work that's being done in Canada that is putting Canada really at the forefront of the global agenda around eye health and public health. And so welcome, Kris. It's great to have you and your 30 plus years of experience on today's panel. We're also very fortunate to have joining us today Senator Mohamed Ravalia. Senator Mohamed Ravalia comes from Newfoundland and Labrador, and it is terrific to have him engaged. He's a passionate advocate for rural health, for inclusive representation, and it really is important to have that political leadership as part of our webinar. Finally, we have with us Dr. Hunter Cherwek. Dr. Hunter Cherwek is Vice President of Clinical Services and Technologies at Orbis International. And Hunter, it's also great to have you on the panel. We're looking very forward to having you as part of the presentations, especially because of the role that Orbis plays in the global agenda. So, without further ado, I would like to call on our first panelist, Dr. Katie Judson. Katie, welcome.
Thanks so much, Drew. If you want to go to my slides, Claire. Thank you. Okay, great. So I'm Katie, as Drew said. I'm the Program Director of Operations for Seva Canada. We're a nonprofit based in Vancouver with a mission to restore sight and prevent blindness in low and middle income countries. On this World Sight Day, the groups hosting the webinar thought it would be helpful to give some context on the global scale before diving into the state of eye care in Canada. Next slide, please. So just a few figures for you here. Almost everybody at some point in their lives will need eye care, like some of you and myself. That'll come in the form of refractive error. For others, it might be things like cataract, glaucoma, or other issues. 90% of eye conditions are treatable or preventable. The great news is that awareness and education, glasses, surgery, or medication can treat or prevent a lot of eye issues. There is an inequitable distribution of vision loss across the world. So 90% of people with vision loss live in lower middle income countries. And this is mostly due to lack of awareness or lack of care availability. The final point is just that sight loss results in $410 billion US annually. This is particularly difficult for people who are living at or below the poverty line. For many of them, vision loss means being unable to go to school or hold a job, resulting in even fewer opportunities to earn money for their families. Claire, can you go to the next slide, please? This graphic from the International Agency for the Prevention of Blindness, thank you, Drew, huge shout out, shows that without significant investment over the next 25 years, the number of people living with sight loss will reach over 1.7 billion people. And this is mostly due to a growing and aging population. But how can we change that? And if you go to the next slide, I'll give some ideas. So I wanted to provide some opportunities that are also some challenges in the global eye health context over the next 10 to 20 years that are on our partners' minds. So I asked a group of our partners from Tanzania, Nepal, and Cambodia what they thought were some opportunities and challenges, and then sort of consolidated their responses into these four main issues. The first is government investment in services and training. So this means national governments need to provide more opportunities for people to receive eye care services. This could be through providing funding for services and outreach through insurance schemes or other funding mechanisms. It could also come in the form of providing more training opportunities for eye care personnel at all levels. This issue will only get more important if the current trend of high-income countries decreasing global aid continues. The next issue is equitable distribution of eye care services. So what our partners are finding and what we're also finding is that even as the number of eye care personnel grows, the distribution of those eye care personnel is not equitable. So generally, people are choosing to stay in larger or capital cities, leaving gaps in services for those who need it most, so people in more rural areas. This is an issue everywhere. It's an issue in Canada as well. This issue can be solved through a combination of technological advancements like tele-ophthalmology, as well as programs that encourage eye care professionals to work in more remote locations. The next is to continue to support and scale awareness and outreach campaigns that work within local contexts. So people only know that vision loss is treatable and preventable if someone tells them about it and provides them access to those services. And it's imperative that we continue to grow programs that work by providing education and access to service to people who need it the most. A brief example of this is our program in Tanzania trains women small business owners in rural towns in basic vision loss identification. And these women know everybody in their community, they're trusted. So when they find people with signs of vision loss and refer them to a local outreach that's being done by the government hospital, people listen to them and go, where they can get the care they need for low or no cost. The final issue is increasing investment in subspecialty services like diabetic retinopathy. So as diets modernize across the world, more people are being diagnosed with diseases like diabetes and high blood pressure, and both of those things can affect the eye. So training is needed across the world to ensure that eye diseases caused by, issues like diabetes and high blood pressure can be prevented and diagnosed and treated early. So hopefully with considerable investment in these 4 areas, we can achieve vision for all. Thank you so much and happy World Sight Day.
Thank you so much, Katie. What a great introduction and a great scene setting for our panel. So I'd now like to call on Dr. Bo Wiafe to present his perspective from beyond Canada. So, Bo, welcome. It's terrific to have you with us.
Good morning, good afternoon, good evening, wherever you are located. It is a pleasure to be able to share some of our experiences, how we managed or we managing to ensure equitable access to eye care for children, the elderly, and the unreached, often underserved populations. Just want to mention that eye diseases or conditions, the eye affects all stages in life, right from the delivery room all the way to when the person passes on. I'm choosing to actually look at 3 groups. We talked about children, the elderly, and the unreached, because these are often left out, because most of the time, the retired people, especially in our countries, go back to the village, go back home, where the services are very, very minimal. We do have some very key challenges that I want us to look at. Yeah, from statistics I have, say 82% of all blind people are aged 50 years and above. But there are 1.4 million children who are blind. Now, this is very interesting thing that we are looking at, because the importance of childhood blindness is not in the numbers affected, but in the number of years a child has to live with that blindness, which is referred to as blind years. Next slide, please. In my country, Ghana, there are currently 16 regions. only 9 of these regions of the 16 have ophthalmologists located there. Even those regions, the ophthalmologists prefer to be based in the regional capital. There is a skewed distribution of ophthalmologists as well as optometrists and other eye health workers. We're lucky the ophthalmic nurses agreed to go to the district, so we have at least one ophthalmic nurse per district. But the point I want to make is that in all these regions where there are ophthalmologists, we do have about we have 4 teaching hospitals, and these are very well equipped. But then they are in the capitals. So the point I want to make here is eye health is available in our countries, but not for everyone. Not for everyone. Next slide, please. This brings me to this equity and equality. The sense that the slide on the left, there is soccer match going on or a football match or something going on, but it's not seen by all of the people. That is equality. There is available in the country somewhere, but it's not accessible to everybody. When you talk about equity, we actually look at the patients or the needs of the people and address them accordingly. So providing eye care services is not enough. Equity is achieved when eye care services meet the needs of different people. And this is very, very, very interesting. Interestingly, we have some challenges that we identified during our recent eye care situation and analysis, and it revealed the following. 1, eye care services financing is inadequate. We do have a national health insurance scheme, but not all the services are included there. Some of the things you have to go out of your pocket and purchase them. The second one is human resources related. And this is very, very, as you saw, maldistribution, inadequate number, and retention issues. And these are very real situations where we've had to deal with. Then we are able to train specialists locally, but then inadequate resources for the residents to train on. Yes, they know the theory, but they haven't even seen the equipment before, and we count it as a big challenge. Then data is another one that we came about because either the reporting is delayed or not fully part of the health information system. So when decisions are being made, the eye is left out. Then not widely integrated into primary healthcare. One theory I've had is that I would want to see the way obstetrics and obstetrical cases are dealt with. A pregnant woman who is in labor can walk into any health facility and will be assisted. That's my dream, to have eye care being delivered at all health facilities. Unfortunately, we are not there yet. It's very important, and it was mentioned earlier, that if nothing is done, the situation is going to get worse because the population is growing. The aging population, people are growing much older than they used to be 20, 25 years ago. And then the lifestyle changes. Now, the question we had was, why? What is needed to provide eye health for all? And we have to identify who the decision makers would be. And then what can we do to ensure access to eye health care for children, elderly, people with disabilities, poor people, unemployed, and so on, with the resources available to us. By the way, in Africa, we have a peculiar situation, in the sense that we are carrying 24% of the burden of diseases. We are just about 10% of the global population. The global health workforce available in Africa is just about 3%. And global health resources available to us is just about 1%. And so there are big challenges that we need to face. So what we did was to try and see what the current situation is. And in 2015, next slide, please, we carried out a National Blindness and Prevention Survey. And we got some very interesting results, in the sense that we have been using 1% as the prevalence, because the WHO recommended that. But when we did the survey, we discovered that the prevalence of blindness is actually 0.74%. 0.74%, not 1%. And the persons with severe visual impairment is 1.07% of the population. We discovered that cataracts are accounting for almost 55% of the blind population, glaucoma 19.4%, and we have retinal issues about 12.8%, and then corneal issues about 11.4%. Now, the most surprising thing was those with refractive errors. We discovered that only 5% of the people with refractive errors actually had eyeglasses. Next slide, please. So as a result of this, we approached the decision makers and other partners, and we're happy to report that as a result of the cataract, about 55% of the blind population due to cataract, the cataract surgical rate was less than 800. The National Cataract Outreach Program was born, and that is helping to actually deal with the cataract backlogs in the country. Second is glaucoma, accounting for 19.4% of the blind population, which is almost every 5 people who are blind, 1 is blind from glaucoma. Now, we use that as an advocacy tool to the government, and we're happy to report that some of the taxes, levies on these drugs were removed, and the prices came down so that the patients could afford. The issue of only 5% having refractive errors, having glasses of those with refractive error translated backlog of about 7 million pairs of eyeglasses. Now, once the word went out, we had several partners coming in with affordable eyeglasses. And I thought this is a very, very interesting outcome of that research that we did. Now, it's already 10 years ago. We're due for the next one to do. So our approach has been using the universal eye health approach, where we want to make sure that nobody should be visually impaired needlessly. Even those with unavoidable blind visual loss should be able to be on their own to achieve their full potential. They get access to rehabilitation and then be able to actually deal with it. And we want to make sure that comprehensive eye services are the ones that we are delivering. The next slide, please. So we looked at, there's a Zulu proverb which says, how do you eat an elephant? The answer is piece by piece. And fortunately in my country, we have a structured system where every district has a district hospital, and the district hospital have health centers around them. And under each health center, we have what we call CHIPS compounds, which are actually health facilities, basic health facilities. Some places we call them dispensaries, manned by community health nurses or a midwife. It's a health post. And so our strategy was first to empower the district hospital, to make sure it's staffed by trained eye personnel. It's equipped the basic diagnostic equipment so that they'll be prepared to take the referrals that come from the periphery. Then we train the frontline health workers in primary eye care. They're able to identify some of these causes of blindness. They're able to know the difference between normal and abnormal eye, and then whatever doesn't seem to be normal, they refer upwards. And this has seemed to be working. We, as operationalized.
Dr. Bo, I'm so sorry to interrupt, but in the interests of time, we do need to move on. Could I just ask you for your final thoughts? It's very interesting. Your Zulu comment then was fantastic. But just in the interest of time, just your final thoughts before we move on to Kris.
So to deal with the backlog of cases in the communities, we identified some active district hospitals and then moved the surgical team to those district hospitals to deliver the eye cases as close to them as possible. And we saw that the uptake was very, very encouraging. Finally, we want to make sure that comprehensive eye care is offered at all levels and try to integrate eye care into the primary healthcare programs. And with this, access is guaranteed for everyone. Thank you.
That's great. Thank you. Thank you so much. And there are lessons there that are applicable to Africa, but also equally applicable in developed health economies. So a terrific backgrounding. Kris Kelm, welcome to the panel. Bringing us back to Canada now with your insights, please.
Yes, thank you very much. And good morning, good afternoon for everyone. Happy World Sight Day. I'm speaking here today in two capacities. The first is as Global Director for International Programs at Operation Eyesight Universal. We're a nearly 63-year-old international development NGO focused on the elimination of avoidable blindness, preservation and restoration of sight, with programs in 10 countries, including Canada. I also am representing as chair the Canadian Eye Health Coalition, which is an advocacy group bringing together a diverse series of viewpoints and positions and decades of collective experience in service of our common mission and a united belief that no one anywhere, including in Canada, should live with avoidable vision loss. The CEHC also includes organizations that are represented here today in Seva, Orbis, and IAPB. So I'd like to begin by saying that we reached in November 2024 a truly historic milestone in Canada. Bill C-284, which is an act to establish a national strategy for eye care in Canada, passed with unanimous support in both the House of Commons as well as in the Senate. For our sector, this was more than just a legislative win. It was a recognition that eye health is a public health imperative and that inequities persist even in a relatively prosperous country like Canada. This achievement was the result of years of advocacy. Data was presented, stories were told, and partnerships were forged by various NGOs, professional associations, researchers, charities, and industry partners. And truly, this stands as proof that when we unite our voices, we can drive real change. In terms of advocacy, it truly doesn't end when a bill becomes law. The challenge is now to ensure that Canada's new national strategy translates into tangible improvements, especially for Indigenous communities, seniors, children, and those living in more rural and remote areas of the country. Advocacy has to remain at the forefront of our priorities. It's not just about lobbying, it's about shaping a system that works for everyone. And as experts, those of us in the eye health sector and watching from various parts of the country and abroad for this webinar, must guide decision makers with evidence, context, and compassion. Coalitions are really important as well, and coalitions like the Canadian Eye Health Coalition amplify the impact that members can give and provide to policymakers in terms of a unified message. They strengthen advocacy by building a unity of purpose. A single message is really hard to ignore when it's spoken by a larger group. They also serve to amplify reach. Pooled networks really multiply visibility. The ability for us to leverage the audience, so to speak, and the network of each of our organizations creates even greater visibility for our shared cause. We increase the efficiency through coalitions as well by reducing the duplication and delivering actionable recommendations in terms of what each of the members stands for and truly represents. And we also enhance our credibility. When clinicians and NGOs and communities speak together, government tends to listen. There's a lesson to be learned from global ecosystems as well. The ecosystems approach where governments, NGOs, academia, industry, and communities align have shown success. Dr. Bo was just speaking of models that have shown success in Ghana, for instance, and I've seen this in other areas around the world where the approach of people working together collaboratively has far more success than individual groups working as silos. At Operation Eyesight, from India to Kenya to Zambia, collaboration across systems has made incredible strides in eliminating avoidable blindness region-wide. Unfortunately, there's still far more work to be done. During my recent visit in India, for example, I was amazed to see how our hospital-based community eye health model, which I think was referenced by Dr. Bo very well, brought together community health workers, optometrists, village vision centers, ophthalmologists, and medical professionals in regional hospitals, as well as NGO workers and industry, to deliver not only compassionate but comprehensive care to rural communities across very broad geographies. The lesson learned through this experience and those of our members is simple. Canada's eye health sector must think as one ecosystem, with each part reinforcing the others, all focused on equitable vision for care for everyone. Bill C-284 gives us a framework. Implementation is now in our hands. Professional associations, NGOs, researchers, industry, they all have a role to play, and advocacy must evolve from influencing policy to ensuring accountability and delivery of those policies. The government is the ultimate duty bearer to ensure systems are structured to enable the health and wellness of Canadians, but we must play an important role in informing the creation of those structures and monitoring their effectiveness. World Sight Day reminds us that vision is both a right as well as a shared responsibility. And as we celebrate progress, let's also look forward to a future where every child can see the blackboard, every elder can live independently, and every community has access to quality eye care, regardless of where they are in our country. Canada is a very vast nation with pockets of population in very sparsely populated areas. Everyone deserves access to the same degree of care and service, regardless of where they are in the country. Where do you see the most critical gaps in Canada's eye health system? How can you help? Please, we would be thrilled to have you join us in this mission. And it truly does take a community to improve the situation for all people in Canada together. So I thank you very much. I wish you a great World Sight Day, and I hope that you're celebrating in a very meaningful way wherever you are in the world or in the country. Thanks very much.
Thank you so much, Kris. It's great to hear about that work. As I mentioned earlier, it's really terrific to see the lead that is being taken in Canada. And so now I would like to welcome Senator Ravalia. Senator Ravalia, as I mentioned earlier, is a passionate advocate for rural health equity and inclusive representation. And we are so delighted to have Senator Ravalia here with us in today's session. Welcome.
Thank you so very much. And let me begin by thanking all of our preceding speakers for the work that you're doing, for your advocacy, and for championing this very important cause. I feel very honored to be part of this esteemed panel as we mark World Sight Day. And I bring to you my perspectives as a rural family physician and medical educator from Newfoundland and Labrador. And this is an important part of my policy and legislative work in the Senate. Interestingly enough, it was very moving to hear from you, Dr. Gold, because I was born and raised in Zimbabwe, where I did my medical training and then worked there for 4 years. And during a 12-month period working in a rural health community in the Midlands, I came to realize how important eye health was. And we had established a structure very similar to yours. But I was particularly impressed by the incredible amount of work that was done at a level of the nursing assistant, licensed practical nurses in eye health and providing care, particularly to those in the Zambezi Valley that were very vulnerable to river blindness. It was partly due to my medical background that I was pleased to help shepherd Bill C-284 and act to establish a national strategy for eye care and designate an age-related macular degeneration awareness month through the Senate. The Senate, of course, is referred to as the Chamber of Sober Second Thought. And we were very pleased to get unanimous support from both houses. I want to thank Kris Kelm. We've had numerous discussions and collaboration, and your work has been particularly inspiring in terms of potentially opening up access for those communities in our country that remain marginalized and vulnerable. The aim of this strategy is essentially to address the gaps and inconsistencies in access and delivery to vision care in our country. Despite being a wealthy, developed nation, eye care remains outside of the availability to many of our populace. Optometry care, for example, is not universally covered. Access to ophthalmology has long wait lists. People are waiting an incredible amount of time, things like cataract surgery. So, part and parcel of the work that we're doing here is to ensure that we improve access and that we're able to pick things up early in the cycle so that prevention and access to care can be readily available. I feel honored to have worked with MP Judy Scroll, who initiated the effort to bring this strategy to the House of Commons. And she has worked tirelessly throughout her career as a huge champion for this particular concern. Our aim is to address the vision loss crisis in Canada, which really does require a coordinated response. We know that over 8 million Canadians, or 1 in 5, have eye disease. There are 1.2 million Canadians who live with vision loss or blindness. There were over 1,200 deaths associated with vision loss in 2019 alone. In addition to this bill talking about a strategy for eye care, it also designates February as AMD Awareness Month, recognizing the unique challenges posed by AMD and an aging demographic. As you're all aware, this progressive condition affects millions of Canadians over the age of 55 and has widespread impacts on their independence, mental health, and quality of life. As our population ages, it is important that we make the public aware of this and that we provide the necessary screening processes. The hope long-term for this legislation is that the strategy will address the wide inconsistencies in access to care. We want to work to prevent and slow the progression of vision loss where possible, help us tailor our services to the needs of all Canadians in a culturally appropriate manner, and allow us to foster research and innovation to better inform policymakers on this issue. The next steps for us are to be all involved in the process of consultation with the government and to hold them accountable to timelines laid out in the bill. We can each play a role in seeing the national strategy moving forward. Continued engagement with members of parliament and senators, as well as close collaboration with groups like yours, Kris, and professional organizations and provincial and territorial health ministries are critical. This bill is particularly important to millions of Canadians and is long overdue. As I conclude, I acknowledge the tireless efforts of all of you on this call, the healthcare professionals, advocacy groups, and individuals who have championed this cause and called for federal leadership. In particular, I want to recognize the importance of us acknowledging the particular need for our Indigenous populations and those living in rural and remote communities. Your commitment to the well-being of Canadians deserves the utmost respect and support, and please be assured that I will continue to be your champion and advocate. Thank you, Merci, Megridge.
Senator Ravalia, thank you so much for those insightful comments and those warm wishes on World Sight Day, and thank you for your commitment to continuing to be a champion for eye health in Canada. It really is terrific to have that particular political support on World Sight Day. Finally, to our panelist, Dr. Hunter Cherwek. Dr. Cherwek, welcome to today's panel, and we look forward to hearing your remarks to close out this learned group of presenters.
Well, first of all, thank you, Drew, and I do want to welcome everyone and say a happy World Sight Day. I'm really actually glad I went last because I get to summarize a lot of the points that other speakers noted. Katie talked about tele-ophthalmology, and if there's one thing I hope everyone writes down from what I'm about to say is the word cybersight, C-Y-B-E-R-S-I-G-H-T. And Senator, you'll be happy to know we were engaging audience members from Zimbabwe earlier this week on this telemedicine platform. I certainly want to thank Claire and all the colleagues who spoke. And when Kris spoke, he talked about advocacy and the importance of a shared voice, but having your data drive your message. And I'm going to end about how CyberSight, the world's largest distance learning telemedicine and AI platform, is providing data to exactly what Kris is trying to put together. And Senator, you'll be happy to hear that Canada is one of our strongest partners. We have some of our most prolific volunteers from Canada. We have an office who's run by Lisa McKean, who's in the audience. And one of your future superstars is in the audience. Her name is Sheetal. She'll be joining us in Ghana, where Bo is currently joining us. So you can see that the world has gotten very connected and very small, and that's what CyberSight's all about. So I'm going to just talk through a few points. I know I'm going to make an American baseball reference, but there is baseball in Canada. I know that. And one of my favorite players had a quote saying, "The future ain't what it used to be." And Senator, I saw you say that. I'm sure you said, "Go Yankees." One of the things when I was going through my residency and graduating 20 years ago, I would have never thought we'd be doing gene therapy. Ophthalmology was the first field in all of medicine to have FDA approval for gene therapy and autonomous AI. And I'm very proud that the CyberSight team, the Orbis team, has leveraged this and engaged key opinion leaders and thought leaders around the world, and including Canada. And we've now published studies and have active AI projects or research in 8 countries. As opposed to most people doing AI where they're doing machine learning, going into countries and extracting data, we're actually using AI to mentor and train local eye health professionals and task shift so that now AI is a force multiplier, not just for patient screening, but patient and eye health professional education. And Senator, one of the things that's probably changed since you and I were in med school, you now can look in the back of the eye at the retina and get an entire view of the patient's neurovascular health. You can predict heart disease, stroke, dementia, multiple sclerosis. We're now looking at the retinas of newborn infants and detecting ROP before it even begins. This is just a snapshot of what CyberSight is, and I know it's a busy dashboard, but Dr. Bo, you'll be happy to see that Ghana is in our top 5. It's a superstar country for us, and our Flying Eye Hospital will be there next month. This is just showing what September is doing on the website. We have over 120,000 registered users, and you can see in the pie graph, it takes a village for a child to get their sight back, and we engage every aspect of the eye health professional community. We have literally hundreds of consults coming through every month. All of this is done for free and engaging some of the best teaching talent in the world, including our webinars where we have many nursing and physician speakers from Canada. You'll see about every, and Claire's been a big part of this, where every month we have thousands of people registering for dozens of courses, and that could be everything from community eye health workers to the very sophisticated, most advanced things in retina, like inherited retinal diseases. So for those who don't know CyberSight, and I realize we have a mixed audience. In fact, some of the people in the audience have contributed to CyberSight, like Sheetal. This started over 20 years ago, where literally a pediatric ophthalmologist returned from a program in Cuba and continued to mentor the doctors through digital imaging and really started tele-ophthalmology, which is exactly what Katie talked about to start this session. I'm very pleased to say that we've now literally done thousands and thousands of consults around the world, including diseases like retinoblastoma, where we linked children to Brenda Gailey and the incredible team at Toronto Sick Kids, and they now are not just saving vision, they're saving lives. To me, what's exciting is we've adopted and have our own in-house artificial intelligence, which we've made freely available to every eye health professional in low to middle income countries, and have done research to show how AI can improve task shifting, where now the eye doctor only sees patients who need procedures, and community eye health workers and even high school graduates are doing retinal diagnoses, looking for everything from diabetic retinopathy to glaucoma to macular degeneration. I know, Kris, you talked about that earlier. One of the things, even with the slowest internet, we're able to provide a patient and their family not just a diagnosis, but an explanation of what's going on within 30 seconds. And we've shown in a randomized clinical trial, which we believe is the first in all of healthcare to be done in sub-Saharan Africa, how AI diagnosis improved patient referrals and compliance with those referrals by 30%. You can see that we've really created a global footprint here, and I'm very happy to say that we've worked everywhere, Senator, from Thunder Bay to now other parts in other provinces of Canada, where we've engaged Dr. Vishal from Thunder Bay, who's now the Canadian Ophthalmic Society Foundation president, and are looking to scale not just around the world, but in your home country. This is just a snapshot of how we're doing these screenings. I get asked a lot when they see the word error, because everyone wants to know how accurate is our AI. Error is not an error in the AI, it's an error in the image capture or the photo that was uploaded. And you can see that up to 30% of patients who are being screened have a blinding eye health condition. That could be everything from glaucoma to macular degeneration to diabetic retinopathy. We're really now, and I know I'm going to use a good analogy for Canada, we're at that hockey stick point where we actually are having exponential growth around the world, and that is including in your backyard in Canada. I could not be more pleased to engage the talent and the professors that we've found from literally Vancouver all the way. I was giving grand rounds in Nova Scotia earlier this year. So I can say that we've really engaged the top talent and technology in Canada. I really appreciated what Kris said. And Senator, I know you're always looking for data to drive budgets, decisions, and policies. This is just a snapshot of how we've used AI and done clinical trials around the world, whether that's in Bangladesh or in Rwanda, or one of our most prolific users of artificial intelligence is Vietnam. I'm going to end as I began by saying thank you, not just to the colleagues and the audience members, but to all the volunteers of Canada who've worked with us for the last 40 years. Some of my greatest mentors have actually come from Canada, whether that's Brian Leonard in Ottawa or Simon Holland in Vancouver. So again, just a huge thank you. And going back to my baseball quote, The future is not what it used to be, but I can't think of a better time to be in ophthalmology, where literally we're deploying technology to the most rural parts of the world, whether that's Canada, Mongolia, or now even Vietnam and South Africa. So a huge thank you to the colleagues, and I look forward to everyone going on cybersight.org and giving us your candid feedback on what we're doing well, but more importantly, what we can do better so we can connect more eye health professionals to training, mentorship, and AI technologies like cybersight. Thank you all.
And a huge thank you to you also, Hunter, for that presentation. I know, having spoken to some colleagues in Ghana this week, they are very much looking forward to the visit of the Flying Eye Hospital. So we look forward to seeing some reports from that. Now, we do have a little bit of time for some questions, and the first one that I have in the chat is a question for you, Katie. You mentioned in your presentation that there is some. Sorry, I'm just trying to pull the question clearly on my screen. In Tanzania, where you were talking about women in the rural areas who are trained to identify people. The question is, what motivation system is in place for these women to refer more people? Are there, for example, financial incentives?
That's a great question. So when the women are invited to the training, they're provided a small stipend for the day. They also receive a t-shirt and food for the day, just, as a part of the meeting. And that's pretty much it. I mean, it's really reliant on their engagement with the community, and they want to support people within the community. We actually did a small study recently to see if women continue to refer people years out. And it turns out that in some of these places, even 4 or 5 years after the training, they're still referring almost half of the people that show up to the outreach activities. So I think the motivation is really just supporting people in their own community and getting them the services they need.
That's terrific. Thanks for that, Katie. It's particularly good to hear about those ongoing referrals. It shows a really, really important level of sustainability. Kris, a question has come through for you, and it is, where do you see the most critical gaps in Canada's eye health system? What opportunities do you see for further collaboration to address those?
Yeah, thank you. I mean, I think that actually one of the most critical gaps has already been filled, if you want to look at it from that perspective, and that's the involvement of government. I think the recognition at the federal level that eye health needs to be a priority within the universal healthcare system is a massive step forward for us here in Canada. Obviously, there's still a lot more work to be done, but I do want to thank Senator Ravalia and MP Judy Sgro for the incredible work that they've done to bring the eye care bill to a positive conclusion and to give us this opportunity to develop a national policy. I think the next step for us is really to find that greater collaborative spirit amongst eye health sector professionals, opticians, optometrists, ophthalmologists, community workers, academic institutions, to build a better system that truly does address the needs of all Canadians. Similar to what we see in some of the more low and middle income countries that several of our organizations work in. I think there are a lot of lessons that can be learned from those models that translate very well to our realities here in Canada. And that is the biggest remaining gap, is the involvement of everybody within the ecosystem pulling in the same direction to address our needs here. Great question. Thank you.
I'm sorry, I need to sign off, Drew. So I just want to say a huge thanks to everyone again. And Hunter, you probably will know that Simon Holland is a grad of my med school as well. And he's always been an incredible inspiration with the work he did with Orbis. So thanks everyone. Let's stay in touch, and I really appreciate this opportunity and privilege. Bye.
Senator,
Thanks so much, Senator. Thank you.
Thank you.
It's been terrific to have you.
You can be the vice president of the Simon Holland fan club. I still remain president, sir.
I might get some inside tracks there. Bye-bye.
Thank you. And Kris, I mean, you just mentioned the importance of bridging that gap between the sector and the political leadership and policymakers. And I think having Senator Ravalia here today was demonstrative of that. So that is really terrific. A question for you, Dr. Bowe, that has come through, and that is what strategy, what is the number one strategy that you think has proven most effective in ensuring equitable eye care access in Ghana? Oh, we've lost Dr. Bowe. Okay, that's no problem. So then there was a final question we have for you, Hunter, is around the most recent community innovations. What do you think is showing the most promise for scaling eye care?
Internet connectivity and artificial intelligence. The ability that I was in Kenya when I was 19, 30 years ago, and I never thought I'd speak to or see my host family again. And now they're teaching me apps on the iPhone. So I would say that Kenya has more than 95% of the population with phones. The connectivity is going to get better and better. I think we'll have global connectivity within the next 3 to 5 years. And I think AI will level all exams so that whether you're the president of the country or someone who's in the bottom billion, you're going to get the same accuracy and the same diagnostics. We're going to be able to see things in the eye that are way outside the eye. Like I said, you're going to go to the eye doctor and ultimately get referred to a nephrologist, a neurologist, a cardiologist. Like I said, I'm big on tech, and I love to see how it's democratized education through CyberSight, how now any doctor in low to middle income countries can access artificial intelligence diagnostics and have a human mentor through the CyberSight e-consult service. So for me, I'm wildly enthusiastic about how technology is being deployed, whether that's in rural Canada or in the most remote parts of Mongolia. So for me, I see technology, specifically internet connectivity, digital imaging, and artificial intelligence as being the game changers in my lifetime.
Well, Hunter, that is a fantastic segue into my closing comments, because, of course, the call to action today is for World Sight Day is love your eyes and help make the case for eye care that is accessible, available, and affordable for everyone, everywhere. And what you were talking about is really the ability to do that, and as you described it, the democratization that technology and AI has brought. So thank you very much for that. Huge thank you to all our panelists. It was really wonderful to have you. Thank you, Katie, Dr. Bowe, for joining us from Ghana, to Kris, Senator Ravalia again, of course, and to you, Hunter. And again, a very, very big thank you to the team who has worked behind the scenes tirelessly pulling this together. It really takes quite a lot of effort to put a program like this together. So thank you to Orbis Canada, to Seva Canada, and to Operation Eyesight Universal. And of course, thank you everybody for giving up your time on what is a busy day, World Sight Day, and for joining us. And as I said earlier, it is great to see Canada leading on some of these pieces of global advocacy and, of course, domestic advocacy. Thank you all very much. And again, happy World Sight Day.